Простите, следующий докладчик профессор Зайдман, кератопластика у детей и подростков. Профессор Зайдман, директор департамента офтальмологии Нью-Йоркского медицинского колледжа, основатель и президент Ассоциации специалистов по детской кератопластике. Please.
Okay. Thank you. There's no slide. The slides are not up there. That's not my slide. Well, while we wait for my slides, I want to thank
Есть кто-то из технической поддержки?
And the member of the organizing committee for inviting me all this way. It's wonderful to come to new meetings, to meet people and share ideas, and to help in the treatment of our patients. Oh, there we go. So I'm going to speak to you this afternoon about corneal transplant surgery in infants and children, primarily infants. This is a very complex and intimidating task. Children are small patients with small eyes. They only make up 2% of all corneal transplants, and there are lots of surgical challenges in operating on these children. So how do we overcome the challenge of pediatric corneal transplants? As I said, the children have severe ocular pathology, technically difficult procedures. They're very young, they're hard to examine. Their corneas can reject overnight in some instances, and even if you get a clear corneal graft, you have to treat amblyopia. So therefore, because of the children's poor layer of cooperation, poor level of cooperation, because they're anxious, nonverbal, uncooperative, and they cannot be adequately examined in the office, all infants and many children, particularly those under the age of 6, need an exam under anesthesia it's crucial to accurately diagnose and manage the child. During the exam under anesthesia, you would have to do a refraction, if you can, a slit lamp exam, check their pressure, measure their corneal diameter, do an A and B scan ultrasound. And I think if you're going to operate on managing these children, you need a non-invasive, an indirect way of imaging their anterior segment, which is generally using ultrasound biomicroscopy. As you can see in this child with Peter's anomaly on the left, the UBM of her eye is on the right, and you can see, you can see synechia from the iris to the cornea, as is typically seen in Peter's anomaly, and her lens was not involved, so she has Peter's anomaly type 1. Now, there's quite a difference in the diagnostic entities between children, infants, and adults. In my experience of over 300 pediatric cases, congenital causes make up 70% of all the children who need corneal transplants, as you can see in the top two photos of Peter's anomaly and sclerocornea. Traumatic injuries, only 10%. And acquired diseases such as keratoconus and scarring from herpes or infections, about 20%. This is very different than my own experience with over 3,000 cases in adults, in which endothelial disease and keratoconus make up 75% of the patients. Now, if you're going to do a corneal transplant on a child, how do you time it out? First, you have to do an office visit. Office visits are usually done between about 3 weeks of age. Then you schedule an exam under anesthesia when the child's about 5 or 6 weeks of age. And then surgery is done usually on the first eye at about 10 weeks of age, and the second eye about 1 month later. It is not advisable to operate on 10 or 12 or 14-day-old children. The technical difficulties of operating on an eye that small are enormous, and usually surgery is unsuccessful. It is much better to wait until the child's globe has grown to the age of about 2 to 3 months. Surgery is not easy, but easier, and though you may risk a little bit of amblyopia, the success rate is better. It is also best to wait approximately a month between the two eyes so you can make sure that the first eye healed without significant complication before you undertake the second eye. Now, this video, I don't know how we get the video to play, but if someone could start this video, please. There you go. This is a video of a baby who had Peter's anomaly who's having corneal transplant surgery. All babies have general anesthesia. They all are given some mannitol to soften the globe. The children are also hyperventilated again to soften the globe. You always use donor tissue between the ages of 4 and 19. Donor tissue under the age of 4 is too flaccid and is difficult to handle. You always oversize the corneal donor by 0.5 millimeter. The typical pediatric transplant is a 6.5 millimeter donor into a 6 millimeter graft, or 7 into a 7 to 6.5. You always use a scleral support ring, and then you begin excising the host cornea. In most of these babies, you have no view into the anterior chamber, so therefore you have to assume that the iris is adherent to the cornea. And the first step is to separate, using a gonial synechiolitis technique, the iris from the cornea, as is being demonstrated in the video. You make a small incision, use large amounts of viscoelastic, and then you slowly separate the iris. Now, this next video shows the difference in size between the pediatric cyclodialysis spatula on your left and the adult cyclodialysis spatula on the right. We have designed some smaller instruments to use on corneal transplants in children, smaller spatulas, smaller scissors, and they make the procedure a little less difficult. So you take your spatula and you pass it into the antechamber multiple times to make sure that there are no adhesions from the iris to the cornea, or if the child has a cataract, to make sure that there are no adhesions from the lens to the iris or the lens to the cornea. It's very difficult to take a cornea off of the eye if there are any adhesions between the cornea and other anterior segment structures, as these two videos will demonstrate. After you've done the synechiolisis, you then turn back to the corneal wound and you use the smaller corneal scissors after once again injecting viscoelastic to slowly excise the cornea. Usually what you do is you excise about 3 or 4 clock hours at a time. The iris begins to prolapse out of the eye, and as it begins to prolapse in the eye, you then will begin putting some sutures in the eye. You will continue your synechiolisis in between the use of the scissors, but you will excise 3 to 4 clock hours, and then what I will typically do, or 5 clock hours, I'll take a 7/0 silk suture and use it to cross the wound to maintain a formed anterior chamber at all times. After having placed the 7/0 silk suture, which you'll shortly see in the next video, I will then start excising the cornea in the other direction and continue the process. We could probably stop this video and go to the next slide. And if we could start this video. In order to deal with the issues of positive pressure, what you're going to see here now is the cornea has been excised, the patient's cornea, in approximately 11 of 12 clock hours, and one 7/0 silk suture was placed to hold the patient's cornea in position. You then take a layer of viscoelastic and place it between the donor and recipient, and then you make a sandwich, essentially, of the donor cornea on top of the viscoelastic on top of the patient's cornea, and you suture the donor cornea on top of the patient's cornea with 2 9/0 nylon sutures. Using this sandwich technique, after you have the second of the 2 9/0 nylon sutures placed, one at 6 and one at 12, you then cut out the 7/0 silk sutures, and after you cut out the 7/0 silk sutures, you slide the cornea out from underneath the new cornea, as you'll see here. So what you do is I remove the 7/0 silk suture, and now I'm removing the patient's cornea, the baby's cornea, from underneath the donor cornea, and then I will excise that. Using this technique gives you a formed anterior chamber throughout the case and almost completely eliminates the issues of positive pressure, iris and lens prolapse, and the need for lensectomies or vitrectomy. Now, if the child does have a cataract, you would do it at this time and then finish closing the wound with 10-0 nylon suture. Also, postoperative care in the infant or pediatric cornea is very different than the adult cornea. The children are examined in the office about 2 to 3 times a week for the first 2 months after surgery, and multiple exams under anesthesia are done in the postoperative period. The first one is usually done about 3 to 5 weeks after surgery, and you begin removing the sutures at that time. The second exam under anesthesia is usually done about 7 or 8 weeks after surgery, and final suture removal is typically done at about 1 month after surgery in these infants. The infants then stay on topical steroids for a year after their surgery. The dose is tapered initially from 8 times a day to 1 time a day. If necessary, they'll be sedated in the office or back into the operating room to monitor their eyes. They get no vaccinations and no immunizations for 1 year after surgery, and you co-manage them with pediatric ophthalmology and glaucoma specialists as needed. In all children, sutures are removed much earlier than adults. As I mentioned, infants usually have all their sutures removed by 1 month after surgery, 2-year-olds by 2 to 3 months after surgery, 3-year-olds by 3 months, etc., etc. It is only usually after a child is older than 8 that you'll be able to keep sutures in for approximately a year. As I said, postoperative care, as soon as the sutures are removed and the graft is clear, you refract the child and we'll have them work with a pediatric ophthalmologist for patching, amblyopia therapy, and a refraction. Now, there are some alternatives to penetrating keratoplasty that will work in certain instances. The picture on the left shows a child who had an optical iridectomy. This child had eccentric corneal scarring. This child actually had a Peters anomaly, but you can also treat children with corneal scarring from infectious disorders if it's out of the visual axis by doing an optical iridectomy. I no longer do rotating keratoplasties. There's too much astigmatism. Lamellar keratoplasties, I've done a fair number of those for anterior scarring. I've yet to do a DALK for keratoconus, and they've yet to be reported in the literature, at least in the American literature, but people are beginning to talk about them. DSEC can be done in a few children, and keratoprosthesis remains an alternative in some children also. If you're going to talk about endothelial keratoplasty in children, you have to recognize that children rarely have endothelial diseases. In the United States today, approximately 800 corneal transplants are done in children under the age of 6 every year, and less than 1/6 of them are for diseases that have endothelial dysfunction. The classic one would be CHED, congenital hereditary endothelial dystrophy, congenital glaucoma, corneal edema, or failed grafts would be the only children that would be considered candidates for DSEC and endothelial grafts, and that's infrequent. I've done a few, but they make up a large minority of the cases. But you can do DSEC. This is a child who had posterior polymorphous dystrophy. You see his pre- and postoperative photos on the right. And you can do DSEC, but you again have to be able to do many postoperative EUAs. When I do a DSEC in a child, I do the DSEC, I examine in the office 1 day after surgery, I examine in the operating room 6 days after surgery, and then often 2 weeks after that, because there's no way to examine a child at the slit lamp to determine if his endothelial graft is in position. So I'm prepared in the operating room to rebubble the graft when necessary. Keratoprosthesis is another alternative for children. Most of you are familiar with, this is the Boston keratoprosthesis. It has a few advantages over human allografts. It can't reject and it can cause astigmatism. However, the disadvantages of the keratoprosthesis is basically a lifetime need for eye drops and contact lenses. There's no way to monitor the intraocular pressure, and has a very significant complication rate, depending on the literature, on pediatric keratoprosthesis between 10 and 50%. My own experience with keratoprosthesis has been fairly good, but I reserved keratoprosthesis for a child as pictured on this photo. This was a 3-year-old who had 6 failed corneal transplants in his right eye and 2 failed transplants in his left eye. His vision was between hand motion and counting fingers in his better seeing eye. And the other eye, the eye we did the K-Pro on, is pictured here, was worse than that. And I still believe that if you're going to do a keratoprosthesis in a child or an infant, it should not be the first operation. You have to have a child with a failed corneal graft and poor prognosis with further grafting with human tissue, and vision has to be less than 2200 in the better seeing eye. Can we advance the slide? Oh, there we go. For example, this unfortunately is one of the patients I did a keratoprosthesis on who developed endophthalmitis. There we go. Oops. Okay, these are my own personal results. This we published about 8 or 9 years ago in the American Journal of Ophthalmology, which were the long-term results of penetrating keratoplasty in children with Peters anomaly type 1. This was a retrospective study of all infants that I had operated on had Peters anomaly type 1. Now, Peters anomaly type 1 is one of the milder congenital diseases, but we followed all of these patients in my practice, and when they were more than 3 years of age and when they were verbal and able to speak, we measured their vision and their function. There we go. So there were 18 children, 24 eyes who had Peters anomaly type 1. Their original age of surgery was an average of 5.5 months of age. We followed them for many, many years. The average child had been followed for almost 6 or 7 years. And as I said, we waited till the children were over the age of 3 so we could test them. Excuse me. We had 21% of the children had rejection episodes, but most of those cleared. 21% of the children required cataract surgery. 4 children had graft failures, of which all 4 were repeated, and 3 of the 4 remained clear. 1 child had a retinal detachment. Glaucoma developed in 50% of the eyes, but was medically controllable in 11 of the 12 eyes and was controlled surgically in 1 eye. After 3 years, 90% of the children had clear grafts, 29% had vision better than 20/50, 25% had vision between 20/60 and 2100, which meant that greater than 50% of the children had vision of better than 2100. None of the children lost their eyes, none of the children were NLP, and most of the children who had vision of less than 2200 had associated glaucoma. In 2006, well actually 2008, the University of California, Davis reported their 15-year history of pediatric transplants. They had 47 patients, 60% of them had congenital diseases, an average of 2 years old. 17% were trauma, due to trauma approximately 6 years old, and acquired non-traumatic diseases such as scarring from infections or herpes, or again greater than about 7 years old. They also had a 54% chance of graft survival, but they did not separate into the groups other than commenting that the older children did better. They also recognized that glaucoma worsened the prognosis, and more than half of their children had ambulatory vision. Our colleagues in Australia, approximately 4 or 5 years ago, reported a greater than a 20-year history of pediatric transplants. They reported over 700 children under the age of 20 who had had corneal transplants done in Australia. Children under the age of 5 invariably had things like Peters anomaly and congenital defects. 56% of their children had clear grafts in that age group. Children between the ages of 5 and 12 primarily had keratoconus, corneal scarring, or corneal opacifications due to trauma or herpes. 80% of those children had clear grafts. And children in the adolescent age group between 13 to 19, 86% of those children had transplants for keratoconus, and 90% of those grafts were clear. They found that endothelial rejection was the most common cause for graft failure. To summarize, therefore, what are the results of pediatric penetrating keratoplasty or pediatric corneal transplants? Graft success is obtainable depending on the age of the patient and the diagnosis and the intensity of the follow-up. Infants with CHED and Peters anomaly type 1, children with adolescents with keratoconus should achieve a 90% success rate. of transplant surgery. Children with congenital glaucoma and sclerocornea will have probably closer to a 60 or 55% chance of success. Their visual development usually seems to be dependent on glaucoma and the treatment of amblyopia, and you have to involve all of your colleagues in the management of these children, pediatric ophthalmologists, glaucoma specialists, and sometimes geneticists. So my son, who's my pediatric co-consultant, sends his best to everybody. He thanks you. I thank you for inviting me. And if you wish to contact us, you can either contact me and my son. You can either email us or call us anytime. Thank you, and have a good afternoon.